Thank you. So the work we are doing, the topic is balancing covariates using propensity score weighting in the context of nonlinear mixed effects models. So very typically, when you talk about early clinical development, there are two main characteristics that do appear. One is you deal with quite small sample sizes. And secondly, you typically have single arm data, so you don't have randomization. There might be a scenario where you have outcome data and you want to evaluate the relationship between the treatment you're giving with the outcome that you get. That is comparing the treatment and perhaps a control, a historical control, and the outcome. And here, there's a challenge of confounding because of the small sample sizes. There might be particular covariates that actually distort that relationship between the treatment you're giving and the outcome. And the result of this is that you have inaccurate or imprecise estimation of the treatment effect. The objectives of our project can be listed into 5. One is to extensively review literature on some key topics, including causal inference, Bayesian inference, propensity score weighting, and tumor growth inhibition modeling as an outcome for these instances. Secondly, to assess similarity in small sample data sets obtained by resampling from large clinical trial databases. Thirdly, to compare anti-tumor treatment effects, estimates, and associated uncertainty obtained with and without Bayesian propensity score weighting methods. The fourth objective is to characterize the impact of selected covariate imbalances on anti-tumor treatment effect estimates in small sample data sets. And the last objective is to tie up this information and try to assess the challenges, opportunities, and considerations when using Bayesian propensity score weighting in nonlinear mixed effects models. So first of all, just brief insight into propensity score analysis. Propensity scores refers to the conditional probability of receiving a treatment, that is either one treatment arm or the other, so a treatment or a control, given a set of observed covariates. In the simplest form, it's represented by this treatment model, in which you have the probability of the treatment assignment, where you have either the treatment arm versus the control. Treatment arm 1, control 0, is given by this logistic regression formulation. You have an intercept, and then you have also a covariate effect parameter. From this expression, you get your propensity scores, and then you weight the propensity scores. There are different methods for balancing weights regarding propensity scores. So you have here in brackets, W1 weights 1, and then weights not, representing how you would attempt to balance the two treatment arms. So there are several approaches, and one of them, you have the inverse probability of treatment weighting, which is very commonly used. Then you have the approach where you perform overlap weights with this expression given here. Overlap weights in particular have been advocated for a lot because they are very effective in balancing covariates that are quite diverse in nature. There are other methods such as the treated approach, matching, and the entropy approach that we do not explore here. So in the more traditional sense, you would fit this treatment model and then extract propensity scores, and then you balance weights based on the propensity scores that you obtain. What is being proposed in this work, what we are undertaking, is actually a Bayesian framework in which you still use the treatment model, but rather than considering your estimates as being exact, you sample from the posterior distribution of these model parameters. For example, you could take up to 1,000 rows. For our instance, we are considering 2,000 rows. So basically, you draw your parameters alpha and beta from the posterior distribution of these parameters. And then you, based on the draws you've made, you're able to calculate your weights. And then what you've already received as weights, you take it into the outcome model. That means you fit the outcome model multiple times. One thing to keep in mind is that given that you've already had about 2,000 draws, and further you're going on to fit, for each draw you fit multiple outcome models, the computational demand is quite extensive. But the trade-off is that you have quite a number of advantages of using this approach. One is you're able to address the question of uncertainty in your estimates. Secondly, you include or account for prior information that improves the quality of estimates you get, and then you have quite some flexibility in parameter estimation. So within this context, we seek, and what we've been doing is to use small sample trial data. But since our starting point is that we do not have this small sample trial data, what we've done is to start from a randomized control trial database, and from it, we sampled using the bootstrap approach, multiple samples. And these are the multiple samples that we then perform the analysis on. Basically, we evaluated the impact of Bayesian propensity score analysis based on these small samples generated. This is the project workflow that we have used. One, partaking the extensive literature review, and I want to state that this has been iterative. In the subsequent steps, when we realize there's some literature needed, we always move back and forth in this literature review. Secondly, obtaining the randomized control trial database from the PRIME study, and then undertaking data selection and high-level exploratory data analysis. Thirdly, developing a workflow for generating the bootstrap data sets. Fourthly, assessment of data sets for covariate imbalances. The fifth step was to undertake the Bayesian treatment model and weighting. The sixth step is comparison of weights impact on propensity scores. The seventh step is fitting the tumor growth inhibition models within a Bayesian context. And then the last step is model diagnosis and summary of our findings. All these steps have been undertaken in R and R Studio, and we've developed the workflows in this tool software. So to start with the master data set that we've used, so we have data from the PRIME study. So this is a randomized phase 3 trial in which 2 treatments were compared. One is chemotherapy, the so-called FOLFOX4 regimen, which has fluorouracil, leucovorin, and oxaliplatin. That is the one arm being used as the control arm versus the experimental arm, which is FOLFOX4 with an addition of panitumumab. And for this study, they undertook it in previously untreated metastatic colorectal cancer patients. So overall, the primary study has 467 patients in the control arm and roughly an equal number of patients in the experimental arm. But what we're interested in terms of data are those patients who have tumor size measurements as an outcome. And we have about 243 patients in the control arm versus roughly the same number in the experimental arm. I'll show you a list of specific covariates that we are interested in. So we have several covariates ranging from tumor size related covariates to different patient demographic characteristics, age, sex, weight, performance status, to variables like tumor histology, number of baseline metastatic sites, and primary site of tumor diagnosis. And the point that we would emphasize here is that given that this is a randomized control trial, there's quite some balancing of these different characteristics across the 2 treatment arms. So this plot shows change in tumor size across time in the 2 treatment arms. So we see that patients who have the experimental treatment, FOLFOX plus panitumumab and FOLFOX alone, we see that the change in tumor size across time is fairly similar across the 2 arms. Based on this study data, we then move on to sample our small bootstrap data sets that we'll use in evaluating the impact of weighting. So for this phase, we've generated 100 bootstrap samples. Each sample has 60 patients. with 30 patients from the FOLFOX alone arm versus 30 patients from the FOLFOX plus panitumumab arm. And then what we do observe is that there's a greater difference in covariate distributions across the treatment arms in the bootstrap samples. What I'm showing here is the so-called love plot, which basically shows, it highlights the degree of similarity in different variables across two arms. So on your extreme left, you have the PRIME study. So basically, this is not a sample data set, it's the original data set. And we do a comparison of the different covariates in the control versus the experimental arm. And the notable observation here is that there is a threshold of 0.1. So the closer you see this diamond point, the green diamond to 0, it means that there's closer similarity in a particular covariate in the two treatment arms. So we can easily say that in the PRIME study, most of our covariates are quite similar in the two arms. But if we look at a picture of the individual bootstrap datasets from bootstrap 1 to bootstrap 4, we see that the green diamonds tend to move away from the reference, which is actually 0.1. And that is sort of the proof that with these bootstrap samples, we're able to get more different datasets across the two arms. So based on the bootstrap workflow, the datasets we generated, we now perform an evaluation of the impact of propensity score weighting on these datasets. I'm going to hand over to my colleague, Marothi, to take us through the remaining findings. Thank you.
Thank you very much, Francis, and hi to everyone again. Given now that we have 100 bootstrap, or should I say samples, data sets, we want to gain control of in some way, because obviously there's these differences that we have seen, but we don't know which one in terms of magnitude, how different they are to each other. So what we attempt to do now, we want to get some magnitude in order to measure similarities or maybe differences. So we chose to use the Goa distance, which tends to deal with several variables types, which can be continuous or categorical. So that's why we chose this. And also we are able to control which variables to focus on. So that's all another power that comes from the Goa distance. So what we do, we calculate those distances, and then from there we average by arm. After averaging by arm, we actually take the ratio of those differences by arm, and then we'll see which one is more than the other. But otherwise, the focus is actually to choose the extreme, and then also those ones that are similar. But at this moment, if you check here on the left for this particular plot, we focus on the 3 here, and then these ones are similar. And then at the end here, we also have some differences, but in the different direction in terms of the treatment. So here I'm actually zooming them down here to actually show the ones that we are moving forward with, which we particularly would reference going forward in the analysis. So the implementation of the treatment and the outcome Bayesian model. I think my colleague has highlighted several things or several steps in the Bayesian model. So this is a logistic regression model, which you would actually fit within the Bayesian framework. And he also mentioned about the prior information. So we also could specify priors on these particular models. Say we know information about a particular parameter here, we can actually specify such a prior or such a distribution, which we'll take advantage of. But for the logistic regression model, treatment model, we have not actually specified any prior, but we've used non-informative priors. Normally, the default priors that comes with the software. For the modified Stein-Fojo model, which is the TGI model that my colleagues talked about. Here we are modeling the log of the observed tumor sizes, given the weights. As we have discussed, this is our main focus. And then also the parameters that we have here, which would be the baseline tumor size and also the growth term, the shrinkage term, and also one thing that we have actually added in here is actually the treatment effect using this beta. So the assumption here, we are saying that the treatment it's acting on reducing the tumor size. So this is a very strong assumption that we have made right now. So next, in fitting that particular model, there are several information that you need to give to the software rather to say 8 chains and how many iterations and how many warm-ups you want to do. So ultimately, if you mention such kind of statement, it means you're going to get somewhere about, in fact, you're going to get 8,000 models, meaning that all the parameters that we've seen above there would be 8,000 of them for each. Okay, and then the warm-ups are those ones that train your model to actually just estimate better. And then now there are 6 scenarios here where we are going to fit this model. There is a marginal model which does not assume individual variability, meaning that we don't say that certain measurements belong to a particular participant. So we just fit in the model like a regression model. And then the mixed model, everyone is familiar with, I think, which is where we have the random effects model. And then for these particular models, we are going to fit them under the unweighted and the 2 weights that we've spoken about. So the reference model here is going to be the unweighted, given that we don't know the true effect size, we don't know the true parameters, what they are. So what we will be referencing from, it's the unweighted, and then seeing what the weights are doing to our models, right? And then now, after fitting the treatment model, we are able to achieve the propensity scores from our Bayesian. So what we did, given the computational power that we had, we actually now calculated the mode of the propensity scores, and then now the weights, we also calculated the mode, to use the mode to weight these particular propensity scores. So given our data sets, we said the first 3 in the extreme were largely different from, I mean, like in terms of their treatment were different. And then we also mentioned the similarities here. We also mentioned the extreme right being different. If you actually check sample 5 and sample 4 and sample 5, 6, you would see that there is a bit of similarities that is happening here. Maybe the goal distance for us is actually working better here. But nonetheless, when you look at the IPW, you see that it's actually trying to balance these particular differences that you see in terms of distribution, which is kind of good. And then you also see that in the overlap, where the overlap is a little bit doing, in some cases, doing more better than the APTW. So now from our model, marginal models, this was very disappointing that our marginal model did not work very well. So if you actually check the estimates, maybe the first unweighted and the weighted IPW, there is a bit of, I mean, there's no good model, good fit, right? Yeah, and then here you would see that the predicted tumor sizes are a bit large. So this is not a good model, a good model fit. So going forward, we are not presenting this, but we are going to revisit it in the next steps. Otherwise, the mixed model here, we see some adequate kind of fits from the unweighted, which is our reference. And then we also have the IPTW, which also fits similar, but a little bit better if you have to look at this particular part. And remember, all these trajectories are different from person to person. So you can't compare this and that and see what happened, but rather the weighting part of it. And then the overlap, it's not really the best, but it's actually doing better than the marginal. Next, we are going to present the parameters themselves, which is the treatment effect, the baseline, the decay, and the growth. So what we want to see here from the reference, we want to see a shift based on the weights. Remember that this is the goal distance that is almost about 0.8, meaning that it's more extreme on the left. So we want to realize some shifts in these particular parameters. But the only shift that we see here, it's in the overlap. And then we remember that the overlap has not fitted very well. So it can be that the model did not fit very well. That's why there is a shift. But we were expecting that there should be a shift in this most of these parameters if the weights are playing some kind of effect on the model. So that's what we did not see. And then moving to the next one, we actually, if you can check, the Goa distance is almost 1, meaning that the Goa distance suggesting that these two populations are the same from the two treatment. So what we want to see here, we want to see no shift, or perhaps a very small shift, but we are not, we still see some shifts here. I don't rely very much on the overlap, but we see a shift somewhere here on the parameter baseline. So perhaps the Goa distance is not a way to go, you know? So, and then from there, we move to the other model, which is almost similar to the first one, to say there should be a shift. Of course, we are seeing some shifts, but we now cannot rely on the Goa distance or whatever shifts that we see now. So I think we need to come up with the next steps on how to actually gain control of this particular models. I'll hand over to my colleague to actually wrap this last part.
Thank you, Marothi. So to summarize the findings we currently have, one, we have been able to develop a workflow for Bayesian propensity score weighting for nonlinear mixed effects models. Checking in literature, actually, I think this is the first time this is being implemented. Secondly, we've been able to implement treatment effect on tumor size, and particularly highlighting the treatment effect on the shrinkage term based on the Stein and Fojo model. What we've observed at the moment is that there is minimal effect of weights, inclusion of weights on the outcome model. But of course, there are a few things that we think could be improved within our workflow. We've recently discussed whether we are actually implementing the treatment effects correctly. And there are a few things that we want to gain control over in our workflow so that we can have some definite way of actually comparing the impact of weights of the treatment effect. And that is one, to gain control on the effect size itself, gain control on the amount of imbalance or the covariate differences across the two arms, and then be able to evaluate at different small sample sizes, not relying on the number 60 that we are using at the moment. So as well of next steps, there are two ways of generating samples that we are trying to explore now. One is to undertake some kind of intentional sampling of the data set we have based on the degree of similarity in the data sets across the two arms. Marothi has talked about the Goa distance, and we think this could actually have a role to play somewhere there. Secondly, we would try to explore the whole workflow using a simulated database rather than basing on a prior database from a randomized control trial. There's an option to maybe also use a simulated database in which we can control adequately all the parts of the data, right, starting from the covariate distribution and the confounding effects. And based on these new data sets, we'll try to explore different model, reformulating our models, one, and evaluating in instances where we do not have treatment at all. Secondly, to fit the different arms differently, fit outcome models differently. Thirdly, to fit one model to all the data set without treatment effect estimate and with treatment effect estimated on different parameters, right? For example, the tumor growth rate constant or even the baseline tumor size. And all of these three options that we are thinking about will implement with regards to the unweighted model which is weighted based on IPW, and model weighted based on the overlap weights. So these are the updates we have at the moment, and we very much look forward to suggestions on how to improve our work. Thank you very much. We thank the APT team, our colleagues, and the faculty for all the support they've given so far. Thank you.
Thanks, Francis. Invite the audience for comment or questions. Noel? You would go with Noel first.
Sure. scales there. Okay, thanks, Francis, Marothi. It was a very nice presentation, and the project it is very interesting. My first question is, maybe you say it, but I just missed it. How do you choose the bootstrap samples, and based on what? Because for the 100 samples, right? You took some.
From the client data, we actually say separate the treatment for treatment, and then we choose that
Random.
with similar place. That is the first data set. Again,
But I think, if I understood you correctly, of the 100, how do we choose the ones we evaluate, right?
Yeah, because I think that you have in one of your slides that you have some samples, and then you say we choose randomly this.
Exactly.
Oh.
So what we're trying to do is to look at a data set where you have treatment arm A quite different from treatment arm B in terms of covariance.
Yeah.
So we use the Goa distance, which looks at how the patients differ within a cohort, for example, in this case, the treatment arm with the other cohort. So control versus experimental arm, how the patients differ. So we went for data sets either from the extreme left, which means they differ significantly, or in the middle where they don't define characteristics, or the extreme right where they differ significantly. Yeah. Just to test all these scenarios. So that's how we chose it.
Okay, yeah, that was my question. Thanks. And I think that, so I think I missed that part. And then if you go to, can we see the slides?
Sure.
You have one, I think Marothi was 1% from that one, where he was saying that the model is not, that he was about the predictions by the model. That is still Marothi. I think that is quite nice that we have it. But even the results were not very promising at this point. I think that is still very stuff. Deep learning.
You mean the marginal model?
Yeah.
Wait for Marothi to share again. And while you pull this up, I have a question on your marginal model. So marginal, you mean as naive pool, you ignored random effect completely, or you are fitting kind of GEE marginal probability type of model?
we ignored random effect completely.
Okay, so it's let us say naive pool marginal. Okay, but yeah, please go ahead.
Thanks. Then so okay. And we go to the next one. That is going to be this. So in the observed tumor size, the observed one, have a lot of, are those zeros?
Yes.
But the model is predicting a higher size, right? Is that correct?
Almost a different size.
Yeah, for example, in most of them you have an observed tumor size of 0, but then you have 2 log scale, right? The tumor size, right?
Mhm.
So are you, I mean, I'm just thinking in maybe in a very decayed way, but Maria is expert here in handling data with that data quantification and those kind of things. But I'm wondering, is it a different way to handle this tumor size, observed tumor size equal to 0? Because I think that the model most of the times it is predicting well when the tumor size is higher than 0. But when it's 0, it is not. Right? Just say that the observed versus predicted tumor sizes are related. The value is higher than 1, but when 0, it's not predicting properly.
Yeah, that's a good observation. We see that for the very low tumor size observations, this seems to be the most straight on the horizontal scale. So it's not entirely performing well.
Yeah, and I'm not sure if there's a way to handle this data. I never put this kind of data before, but I'm assuming that it should be another way to handle.
That's what we did. Yeah, I think what we did also due to on the zeros, because we had to log them.
Yeah.
We put some small kind of increase there So I'm not sure, maybe that is the handling, wrong handling that we did. Maybe there's some way of doing that.
I think, yeah, there's no truncated models. So that when you're predicting, you're taking into account that the model is applicable. For
Yeah,
these
we have a
truncated
few
space.
methods basically that you can apply on this method. So if you have additional questions, we can keep it for the open discussion now that we have Robin with us. I know you don't have a lot of time. Welcome. So, and thanks, Francois. Any final words from your end?
No, I just want to again emphasize the fact that it was really nice so far, and we will continue, of course, to work with Francis and Marothi, as well as with Anna and Antonio. It's a challenging topic, but we have learned a lot. So real pleasure and to be continued. Thank you.